Thank you for joining me today. In today's presentation, we will explore the Neuman Systems Model. As some of you are aware, I've encountered a little bout of laryngitis. I appreciate your patience and concern. My name is Betty Neuman. I was born in 1924, the middle child, raised on a 100-acre farm with two brothers near Lowell, Ohio. I was raised by my mother after my father's death when I was 11. I've had a strong nursing influence in my life due to two factors. The first being, every time my father came home from the hospital after his hospitalization for kidney disease, he would speak with the highest regard for the nurses that cared for him. The other was from my mother. She was a rural midwife, and this contributed to my desire to help and care for others. And I knew what I wanted to be when I grew up. I wanted to be a nurse. While saving for nursing school, I worked odd jobs and helped support my mother and younger brother. My nursing career was expedited by the development of the U.S. Cadet Nurse Corps, a program that ran from 1943 to 1948. As a nurse cadet, I was part of a massive, important federal program for the training of American nurses during the Second World War. As a cadet nurse, we were the largest and youngest group of uniformed women to serve our country. It was a time when nursing students lived together in nursing residence, when boys went off to war, and when cadets cared for civilians at home and those who returned home after being injured in battle. I suppose my experience as a U.S. cadet nurse developed my interest in community and public health. For my nursing experience, I lived in Los Angeles, California, where I obtained most of my experience as a staff nurse. As I worked my way up the nursing ladder, I also advanced my formal education by obtaining my BSN, MSN, and PhD. I've worked as a faculty chair at UCLA. I've developed the first community mental health program in Los Angeles. I am an author, a lecturer, a consultant for nursing and interdisciplinary healthcare, and I've worked in a variety of settings such as med-surg, critical care, and communicable disease nursing. Currently, I live in Waterton, Ohio, and I work mostly as a consultant and work as an author. The origins of my theory is it was developed as a tool. It was developed to be created and used for and by nursing students that I was teaching at UCLA to facilitate their integration of the four elements of a human being at the time. In 1972, after 2 years of evaluation, my tool was expanded and developed into a model. It was first published in the May-June issue of Nursing Research. It was titled A Model for Teaching Total Person Approach to Patient Problems. My theory is a grand theory. It is a conceptual framework under which the key concepts and principles of the discipline can be defined. It meets the criteria of a grand theory in that it created a different way of looking at a particular phenomenon, particularly how a client is viewed, such as an individual, family, group, community, or an aggregate. Theories must be logical in nature, which is evidenced by my model diagram. Theories should be relatively simple yet generalized. Theories can be the basis for hypotheses and need to be tested and expand the general body of knowledge with research to validate them, which we'll discuss later on in my presentation. Theories can be used by practitioners to guide and improve their practice, which we'll also discuss in a later slide. And theories need to be consistent with validated theories and laws, which we'll explore on the next slide. Then the tool became a model. The evolution of my model was influenced by a variety of sources, but most particularly the philosophy of writers such as Desjardins. He was a Catholic priest and scientist who is credited with the idea of spiritual evolution. The Gestalt theory by Hans Selye is a dynamic interaction of the individual and situation determines experience and behavior, meaning that no two interactions will ever be the same. I also was influenced by the general adaptation syndrome, which postulates that there is a nonspecific response to stress involving 3 stages: alarm, resistance, and exhaustion, which I'm sure we're all feeling about now. The general systems theory grew out of a field of thermodynamics, a branch of physics, chemistry, and engineering. So as you see, my model and theory is based on an interdisciplinary approach and has grown from other disciplines. For the purpose of time, I will focus on the 4 nursing paradigms. Nursing, I define nursing as an action which assists individuals, families, and groups to maintain a maximum level of wellness, and the primary aim is stability of the patient-client system through nursing interventions to reduce stressors. The role of the nurse is seen in terms of degree of reaction to stressors and the use of primary, secondary, and tertiary interventions. I see nursing as a unique profession that is concerned with all the variables which influence the response a person might have to a stressor. Next, environment. I consider the environment to be a totality of the internal and external forces, which include intrapersonal, interpersonal, and extrapersonal stressors, which surround a person and with which they interact at any given time. There are 3 environments: our internal environment, which exists within the client system, the external environment, which exists outside the client system, and the created environment, which is developed unconsciously by the client as in symbolic of the system's wholeness. Next, we'll look at the definition of person. It's a human being as a client system, and the person is a layered, multidimensional person with 5 variables or subsystems: physiological, psychological, social-cultural, spiritual, and developmental. Finally, we're going to look at my definition of health. But before we look at my definition of health, we have to look at some of the main concepts or key concepts for you to understand my model diagram. Lines of resistance are how an individual and their body respond to the environmental stressors, determines which line of defense is activated. The LOR attempts to stabilize the client system and foster a return to the usual state of wellness. There's the normal line of defense, or the NLD. The NLD represents a system stability over time. This is the line that represents what the client has become or evolved to. It can change over time in response to the patient's coping or the response to their environment. Next is the flexible line of defense. The FLD is the outer barrier or cushion to the NLD, the LOR, and the core structure. If the FLD fails to provide adequate protection to the NLD, the LOR becomes activated. The FLD acts as a cushion and is described as an accordion that expands away from and contracts closer to the NLD. Thus, it's a dynamic situation that can be changed and altered in a relatively short period of time. I'm also going to include my description of a stressor. I consider a stressor to be anything that impacts the health or creates stress within an individual. Stressors are capable of either having a positive or negative effect on the client system. A stressor is an environmental force which can potentially affect the stability of the system, and they may be, which we reviewed earlier, intrapersonal, interpersonal, and extrapersonal. I define health as being equated with wellness. It's a condition in which all parts and subparts, such as variables, are in harmony with the whole of the client. As the client moves towards illness and death, more energy is needed than is available. If the client is moving towards wellness, then more energy is available than is needed. Finally, we'll discuss reconstitution. Reconstitution is the increase in energy that results in relation to the degree of reaction to the stressor. Reconstitution begins at any point following initiation of treatment for invasion of stressors. Reconstitution may be expand the normal line of defense beyond its previous level, stabilize the system at a lower level, or return it to the level that the client was at before